Morning, everybody. Today is May 25th. We are doing QHSC Training Airway and Management Part 2 with Dr. Mape and Dr. Randall, who will be joining us later. So I'm going to let Dr. Mape go ahead and get started. Thank you, everybody, for joining us.
So good morning and good afternoon all. My name is Dr. Mape Said. Today I'll be the presenter of this presentation, Airway Management Part 2. As you remember, we did Airway Management Part 1. And let's say the center of this presentation is Dr. Gwen Randall, who will be with us very soon. So our main topic, the topic of today is how are you going to develop a difficult airway catch or a trolley? So we will focus more on the difficult airway catch. And next slide. Dr. Gwe, out of our presentation we will pass through all our objectives will be know how to define a difficult airway. We will also check on the difficulty airway catch and the trolley. Also to put to know exactly the content, what should be in the difficult airway catch and the correct placement of the difficult airway catch in a hospital environment where we could place it properly so anyone can know where it is. It can be achieved very easily, so it can be useful and helpful to the patient. Okay, next slide. Welcome, Dr. Gwen.
Good morning.
Yes, good morning and good afternoon here.
Yes.
With the presentation.
Uh-huh.
We are up, so you didn't miss a lot. So the difficult airway, we can define it by saying that when you enter with the difficult with the chest mask ventilation, difficult with trachea intubation, or both. And this has to happen in a clinical situation by a conventionally trained anesthesiologist. So this is the simple definition developed by American Society of Anesthesiology about 2003. So whenever you enter difficult with a chest mask ventilation, whereby you cannot properly administer oxygen through a face mask to the patient, or you have problems, you successfully do a face mask ventilation, but you have difficulty in intubation, meaning that you can't place endotracheal tube into the trachea of the patient, or having trouble with both. But this has to be a clinical situation and done by a trained anesthesia provider or conventionally trained anesthesiologist. Okay. So next slide. So upon this definition of difficult airway, we would look about more on the anatomical difficult airway, whereby it all lie on the patient. So here we have everything in hand. The instruments, the equipment, the supplies are there, but patient's anatomy gives us difficulty in maintaining the airway. Also, we can have different pathology or physiology of the patient's response, whereby it gives us a difficult time to maintain a patent airway, to oxygenate the patient, or to ventilate the patient. And also the definition can go in a very big spectrum, whereby now you have a situational aspect. Everything is fine for the patient. Everything is fine in terms of anatomical and pathology or physiology of the patient, but it's something situation. I am in the environment whereby I have limited resources or limited human resources that give me a difficulty in maintaining airway of the patient. And also the definition can go beyond even the equipment. You don't have a proper laryngoscope, you don't have a proper mask, so you will not be able to oxygenate that patient or to secure the airway if in need. Okay, so the next slide. and sometimes even the professional capability. That's why in the definition we say that it should include a properly trained anesthesia provider or conventional anesthesiologist. Because if you ask anyone who is not properly trained, he will have some difficulty in maintaining airway just because he was not trained properly for that job. Okay. So next slide. So the complex of difficulties that we are talking about lies even in the definition, because sometimes the definition can go in a spectrum from anatomical, pathological, situational aspects, or professional issues. So also there is a difficulty in management also. When someone has airway obstruction or airway issue, it's also difficult to manage, and even documentation. So it's a complex of difficulties, because at the time that you are trying your best to help the patient, you will not be able to document if you have a limited number of people at that time. So you will have to do something meanwhile, and later you will have to sit and document. So sometimes it's difficult also to remember, what did I do? What did I give to the patient? So you need a teamwork to achieve this. Next slide. So it can start with difficulties and end with failure. So I might have a difficulty in airway management, but later I can be successful, can achieve oxygenation and ventilation. But also this difficulty can go to the spectrum to be a failure at all, that I cannot oxygenate the patient and I cannot intubate the patient. So you fail to do anything. Okay, let's continue. So again, we are in the definition. So the difficult can be a massive ventilation, doing direct or video laryngoscopy, difficult in trachea intubation, difficult in utilization of supraglottic devices, examples LMA, and also I can incur difficulties on doing the front of neck airway, trachea, perodotomy, or tracheostomy. And sometimes the definition goes on the spectrum of even at the end of what you successfully intubated the patient, at the end you incur problem during intubation. The patient started the saturation, inflammation of the airways. So it's also included in the difficulty. So the updates on this definition might include, you might require multiple attempts to achieve the secure of airways, or you might need more than one operator. And here is the concept that call for help. If it's something planned, you call for help before, but if it's emergency, you call for help and you utilize everyone who is there at the available resources. Okay, so next slide. Or you have anything to add, Dr. Gwen, before we proceed? Okay, so the incidences presented by Ala Mazi 2020. So it was found that the type of difficulty that is faced, for example, if someone faces difficult intubation, the difficult incidence is about 1.2 to 3.8. And there is a chance that one among the 1,000 might fail to achieve oxygenation and ventilation, mostly in elective cases. But in obstetric cases, one among 250, you might find yourself that you failed to achieve oxygenation and ventilation. And much worse in emergency situations, one among 100, you might find yourself that you failed to achieve oxygenation or intubation by intubation. So also there's an incidence rate of using supraglottic airway devices, which is 0.16, and face mask 0.01 to 5%, and also difficulty in doing laryngoscopy. Okay, so this was the study done by Alamazi 2020. We will continue. So the high incidence is on intubation, difficult intubation.
And I think the most important thing is to recognize that you have a difficult intubation before you get yourself into a situation. So making sure that you do a proper assessment of the patient prior to intubation attempts.
Okay, thank you, Dr. Wayne. And that's what we will be talking about when we were preparing the difficult airway cut. That means we already anticipate, and now we want to prepare the difficult airway. So we'll continue with the next slide. So also, as we said, we will focus more on the anatomical or situational aspect, but you might face physiological difficult airway. For example, when you have deficiency or problem with your oxygenation, you intubated your patient, you are giving oxygen 100%, but still your patient is hypoxic. So there is oxygen deficiency, and this is not due to anatomy, because you successfully secured the airway, but this lies on the patient's physiology. So also you might have problems with ventilation, whereby you are ventilating your patient, but your patient is acidotic. So there is a deficit in ventilation. This lies on the physiology. And also sometimes in shock, you have issues with perfusion. So patients with pulmonary edema, anemia, that's physiological. You might not achieve 100% saturation because of the physiology and not anatomical difficult airway. So next slide. So when you enter with a difficult airway, the Difficult Airway Society has created a plan or algorithm that will help you and guide you and aid you in what you should do next. So for example, I have several plans, plan A, B, C, and D. So in plan A, my main goal is to do face mask ventilation, and trachea intubation. And this is my safety plan. So I will do the laryngoscopy. If I succeed, you do the trachea intubation. But if you fail to do laryngoscopy, you have to opt for the plan B, because we say that the spectrum of difficult airway lies on the face laryngoscopy, trachea intubation, use of supraglottic airway devices. So we started with laryngoscopy. Can we do the laryngoscopy? So we did the laryngoscopy, and we succeed. Now we did the trachea intubation. But if you fail to intubate, now you opt to go to the plan B, whereby you will be maintaining oxygenation by using supraglottic airway devices. This includes LMA, which you will use as a risk. So if you succeed to oxygenate the patient with the LMA, you will have now to stop and think of the options. Should I wake the patient up? Should I intubate using the supraglottic intubating LMA? Should I proceed without intubating the trachea? Or should I opt for tracheostomy and epicocitosis? So you will decide, or you will make a decision depending on what the procedure, what the aim or that I want to do an intubation for this patient will mandate your choice. Again, when you fail to use supraglottic airway devices, Now you will have to go to the plan C, and the plan C, now you have to attempt again face mask ventilation, and here it's the final attempt at the face mask ventilation. If you succeed, now you will have to wait the patient because continue its risk for the patient. And if again you fail to do a face mask ventilation, now we will go to the plan D, whereby we have to do front of neck airway access. And this has to be emergency mucothyroidotomy or tracheostomy. So in this plan or in this algorithm, will also help us or guide us on how to arrange our discharge airway cut. So we'll see when we start to presenting about airway cut, so we can continue. Anything to add from Dr. Gwen?
No, I don't have anything to add to that.
Okay, so we will continue. Next slide. So now we will talk about the difficult airway cut or trolley. So this is a shelf I think most of us have seen in hospital ground. So this is a shelf with the drawers, and it should be mobile, movable, can move from one place to another. It has almost 4 wheels that should be working well, so you can move it from one place to another. It should be robust because most of the time it is used by many people running a lot, so it should be strong to handle those stress. Clearly labeled. So every draw should be labeled. That's what is in this draw. And also all the algorithm for discharge airway developed by Discharge Airway Society should be attached to this trolley. So it could help you or guide you in the situation of discharge airway, like the algorithm we see in the last slide. Okay, next we can continue. And there should also be a restocking list whereby each day in the morning you check the list and you check that if you have any supply that has been used, you have to replace. If it's a drug, you have to replace. If something is not there and it should be there, you have to replace. So restocking list should be done regularly. So there's a top wet surface, a top wetting surface, and it should almost have 4 to 5 drawers, totally in logical sequence, because we said the difficult airway society algorithm will help also us how to arrange this. It should be clean, because clear station help you to remember. Attach documents, we'll see which documents we should attach there. Also, that guidelines and the restocking checklist should be there in this scrolling. So let's continue. So clearly labeled, this is example of how you should label this trolley by writing the labels like face mask, but also putting labels that indicate that this pictorial presentation, this is a face mask, this is airway. So it makes it easy. Sometimes in a situation of emergency, you cannot read, so you see. I see a picture of endotracheal tube. Now this is a drawer for endotracheal tube. This is the drawer for supraglottic airway. I think everyone can appreciate the drawer. Okay, let's continue. And also well organized. So when you open your drawer, everything is well organized. For example, well organized in terms of size and type. So if you have endotracheal tube number 7, 7.5 in diameters, or 6, well organized. So it could, you can check the exactly number that you want. Okay, let's continue. So now we will start to arrange our airway discharge cards in terms of contents. What should be in the airway card? So the top of the trolley, the working surface, you should put your flexible intubation fiber scope, portable scope with battery and light. These are delicate equipment or instruments that you should handle with care, because if you don't put it well, it's very easy to block or to destroy. So on the top of the trolley, we will put a flexible, those fiber scope and the portable scope with the source of light. And on the side of the trolley, we will hang introducers like bougies, filety, intubation catheter, and airway extent catheter. So these will not be in the drawers, but they will be on the side of the trolley. Okay. Now let's continue. Now, talking on the top of the trolley again, we will put some airway algorithm flowchart, like the last one, a brief cognitive aid that will help us and drag those charts, and also contact, for example, of senior anesthesiologist, ENT surgeon, or intensivist. So in emergency needs of them, we should have their contact ready, so we can call for help. Okay, next. So we start with the drawers. So drawer number one, the drawer number one will help us with the plan A. So in plan A, we say that our main aim is to do face mask ventilation and intubation. So we will here, we have to optimize the head position of the patient already. We have to utilize the bougie and also having alternative laryngoscope. So if you have a conventional laryngoscope and a video laryngoscope, and the content should be bougie, which ideally we say it should be on the side of the trolley. Short handle laryngoscope, you can have McCoy blade or straight blade with your video laryngoscope. So the plan here is to do face mask ventilation and the tracheal intubation by doing laryngoscopy. So you have your things ready, the safety floor and the safety drawer, I mean, that will help you with the plan A, which is face mask ventilation and laryngoscopy, then it's tracheal intubation. Next slide. So this drawer also will continue syringe like 5 cc and 10 cc for ballooning of the endotracheal tube. We will have the Maggie faucet. We will have the adhesive tape for securing the tube, the bite blocks, and the lubricant. And also, most important, drugs that will help us, like roxuronium, the muscle laxant for intubation, and also to have the pre-printed labels for succinylsonium for the drug. So you have a pre-printed label for succinylsonium for roxuronium. So you don't have now to write again on the syringe. Also, just take the label and put on the syringe that you draw your drug. Okay. So now this is what should be in our plan A of face mask and tracheal intubation. So everything that's in that draw is like presented here. So we will have our blade for laryngoscopy that will help us, the Maggie faucet, the tape, the drug, the fillet, and the tube. That they should be ready. Okay, let's continue. So that was the draw one, which went with the plan A. So the draw two, we went with the plan B, whereby in plan B now we want to utilize supraglottic airway devices. So here we will have the LMA, which will also be followed by fiber optic intubation through the LMA. So we will have the LMA, intubating catheters, which ideally should be on the side of the throat, and all the fiber optic adjuvants, like the Opacian airway, things like that. So on the next slide, we will see, slide, please. What should be, also we will have the lubrication gel again for LMA inflation, orogastric tube, tongue depressor, and a 20 ml syringe. So in the next slide, we will see what should be. So the main here is having your element of different sizes depending on your patient. You have a suction catheter, you have a tongue depressor, and you have a gel like a lidocaine to spray to reduce the airway responses. So this will help you or will risk you in terms of to intubate during assessment. So you use the element, and once you successfully utilize the LMA or supraglottic airway devices, as you remember now you have to stop and think. Should I continue? Should I wake the patient? What should I do? Depending on the type of procedure or your aim of doing all of this. So we will continue now. So this is our drawer 2, went with the Planier C. Okay, so these are the fiber optic adjuvants like the Bayman of a Sapien airway, fibroscopy, nasal sponge, that you should also include them, or you can store them in the separate storage box. So we'll continue with drawer 3. Next slide. So the drawer 3 went with the plan C. So in the plan C, now we wanted to attempt a final mask ventilation. Now we failed to intubate. We failed to utilize the supraglottic airway devices. Now we do the final attempt of mask ventilation. So we should have mask, airway, oral airway, and nasal airway. So the contents here will be face mask of various sizes, oropharyngeal airways, and nasopharyngeal airways of various sizes. Next slide. So in drawer 3 also we can have a series of 10 cc and a reversal for muscle relaxant, sugar mandate, should be in this drawer. Okay. So this is our draw for plan C, because now we want to attempt face mask again. So we use the face mask, we use the airway to try to do big masking to achieve ventilation. Okay, so on the next slide. So in drawer 4, now we failed to utilize again the final attempt to do face mask. So now we go to plan B. So the plan B involves, now you declare that I cannot intubate this patient, and much weight, I cannot oxygenate this patient. So can't intubate, can't oxygenate. So the aim or the plan here is to go to front of neck airway access, whereby in plan B, we include surgical cricothyrotomy or tracheostomy. And the content here should be a large bore cannula that will help us with the crico to achieve airway access through front of the neck, a scalpel, trachea dilator, bougies with cuffed tracheal tube, small tube number 6 or 6.5. That could give us access to the trachea, depending on the which supply you have. Sometimes you can improvise. Don't have the properly prepared instruments, you can improvise. So next slide. And meanwhile, I would like to welcome all who are joining now. I hope everyone can hear the presentation. So you have your emergency critical thyroidotomy catheter stage, which include everything. And you have the scalpel, you have a bougie. Sometimes you need a bougie to help you to introduce your endotracheal tube into the trachea. So this is a very simple set where you have, and sometimes you can even use a cannula, a large bore cannula, to achieve a cannula or needle cricocytotomy. This is for surgical cricocytotomy. So next slide. So also in the same drawer, a cannula cricocytotomy, because you don't have the surgical set for cricocytotomy. Now you want to use the cannula cricocytotomy. So the contents will be resistance gauge ventilation with a high or low pressure ventilation system. So here we don't put the tube. So here we just put the cannula and we connect it to the gate ventilator, whereby the aim is to achieve oxygenation. Okay. So next slide. So the aim is to achieve oxygenation. So miscellaneous, we should also have the dust guidelines or locally agreed algorithms according to the department or institution. Equipment checklist for restocking that should be done regularly. Logbook for daily checking procedures, specific extubation aids or equipment, and also might have extubated guidelines which are laminated and attached to the trolley. So next slide. So upon saying all those plans, I will also say something about the plan and the strategy. So the aim here is to develop an airway plan. An airway plan, it is only a single approach, the management of airway. So you have a patient or you have a candidate that you plan, I'm going to anesthetize this patient, or I will use the endotracheal intubation to secure the airway. So that is the plan. So when one plan fails, you don't have another plan. But in an airway strategy, you have a lot of coordinated logical sequences of plans. So the aim is to achieve a good extended prevention of vasculitis. So anesthetists should approach airway management with strategies rather than plans. Because if you have strategy, you say that I will intubate this patient. But if I fail to intubate, I will use the supraglottic airway devices. What if I fail to utilize the supraglottic airway devices? I will have the mask in the airway and attempt to face mask ventilation. If I fail, I will opt to do cricocytotomy. So that's the strategy and not just the one single plan. So we should have sequence of plans whenever we plan something. So this is just a very good option to have rather than having a single plan. So another accessory that we will really help you during all of this is to have a suction machine, suction tube, and catheter, and should be tested if it's working. Because this, you will not have a suction machine in the cart, it should be in a separate entity, but you should have it ready. It will help you. So the next slide. So also in developing a strategy, a difficult airway management strategy, we should have a generic strategy before each list of case. So whenever you have an elective list, a strategy should be available before you start the list of cases. And a specific strategy before anticipated difficult airway cases. So you might have also anticipated difficult airway, or you start using your patient. So the reinforces here are knowledge, preparation, and teamwork. These will help you in achieving the same goal of body air gas exchange and the prevention of aspiration. Next slide. So in providing all of this, you should ask yourself, do I have the right equipment? are they in the right amount? Or are they in the right place? And also at the right time. So you should plan, you should communicate, you should prepare and train. You plan your things that I'm going to do in the intubation. But if I say I have to have another plan, so you create a strategy. And also you have to communicate. If you think there is a need to have an ENT surgeon ready or a senior anesthesiologist ready, communicate before you start. And the preparation, you prepare for a difficult airway, or you prepare your airway difficult airway cut early. And the most important thing is to train. You should train yourself in management of airway. And if you get that access, you should train others. In that way, you create a team that everyone is capable of doing the right thing. Okay, so next slide. So now we will talk about the placement of a difficult airway cut. Where should we place a difficult airway cut trolley? So it's almost uniformly concluded that a difficult airway cut should be placed at all locations where anesthesia or intensive care is provided. So it should be immediately available in the places and readily at handy, or within 60 seconds, it should be available. So it can be placed in any room, but its accessibility should be readily at handy or within 60 seconds. So whenever you're going to do anesthesia, or you are in the intensive care ICU, you are in the emergency department, you should have this difficult airway cut. Okay, next slide. So now the last picture. I want to talk about the last picture. Last slide, please.
The previous picture, Bree, before the references.
Yes,
yeah.
We want to talk. So, as we can see in the picture, now they are asking, is this the end? I mean, the end of the patient. Now the saturation is 49, and they are using oxygen about 29. So you can see, if you don't prepare yourself well, you don't have enough a sequence of plan. You didn't prepare well your equipment. You will be getting in trouble because you don't have a strategy. You fail to intubate. You don't have another option. You don't have the LMA ready. You don't have the quick the quick help that I have a senior. I communicate with the seniors. They will help me. So you will you compromise the patient health, creating injuries and disability. So preparation to be ready is very important. So being this the last picture, I all thank you for listening. Now I would like to welcome Dr. Gwen. Dr.
Yes.
Gwen, welcome.
So, welcome. So what I would like to say is, what are some of the challenges that the participants can anticipate? And then I want to also let you know that if you can't have a big difficult airway cart, then there are some other options. And those options are, you can get a fishing tackle box, which has the 3 tiers to it, and you can start to stock that so that that is portable no matter where you go. And so what I found out from having been at one of the hospitals is that there really is no person assigned to do airways, and then there's no team available to help. So get yourselves organized in terms of where is the cart. If you don't have a cart, then what is your strategy going to be? So, what I'd like to hear from the participants is what are some of the challenges that you think that you would face in light of a difficult airway and managing and having a cart?
Okay, now we are listening for in the response for the question from Dr. Gwen. And also, if you have questions, you can write in the chat. And also remind the host they should write their names and email in the chat.
In the chat, yes.
Okay.
And
So
what
everyone
hospital they work at.
you can write in the chat what hospital you are working, your email, and your name. I think it's for the certification of this presentation. Okay, so as to receive a certificate for participating in this presentation.
Yeah, I got a question, Dr. Gwen. So my first question would be, how is there communication that's going to be initiated at that point, or is it just an individual who will then have to respond by themselves? And if there is communication, then how does that start out, or how would they normally do that? So,
Well, then there needs to be some kind of planning and a team because what we found is that anybody and everybody can respond to a crash or code situation, but not everybody knows what they should be doing. So this should be preparation that takes place within the hospital during the course of the year, especially within the departments, like who's on first and who's supposed to do what. So it's called team dynamics and team training so that when you have an emergency, everybody knows what they should be doing.
thank you.
Mm-hmm.
Okay. Anyone else with a question while you are writing the hospital you are working, your name and your email in the chat, so you could give a certification of this presentation.
Dr. Mape, I have a question. In Tanzania, do they, at the beginning of the day during huddle, when you guys discuss something, do they assign a certain job if you were need to get the crash cart? Is there like a team lead? Is there someone who handles the medication drawer?
Yes, in most of the crash carts, we have a book which all the drugs, all the equipment that you have. So in every morning, you should be checking that what you used yesterday and now you don't have, or they were 5 and now they are 3. I have to restock. But it's very hard to maintain every day because of the few numbers of people and sometimes not available at all. So you have a limited resources. For example, you have out of stock of things. So it's hard to restock. So things like that. But in every crash cart, there's a book.
Thank you.
So it's a challenge. Okay.
And who's responsible for maintaining the book and also making sure that the drugs are replenished once they're used? Is there a person assigned to do that or not?
So from what I see, for example, if you have a crash cart in a recovery, a person who is job allocation that day is in recovery and is in charge is responsible for restocking the crash cart and to check what is not there. So you look at the job allocation. If you are in that place, now you are in charge of it. You are responsible to see and to check. And whenever you enter in your shift, you should also check. Someone checked in the morning and you enter the night shift, you should also check. You have that responsibility to check because anything happening, you will find nothing there. So you should check before you get any client or patient. So here, it's obvious generally that if you are there, you are responsible in that room. So we should also have like a responsibility that you should check it, rather than leaving it to the general purpose that everyone who will be working here should check the card. We should announce that this is a responsibility. You should check it.
So what we did at Maya Mala Hospital is in the ICU, for an example, when we had the crash cart, once the crash cart was actually, or the difficult airway cart was developed, then the charge nurse who has the keys, that charge nurse was responsible for each shift to make sure that the cart was stopped. So there has to be a designated person who's going to be responsible. And if that person can't be responsible, then who will? And so this basically starts the chain of communication on in terms of how things are done. So developing a team or some kind of, like you talked about, airway strategy, there still needs to be a strategy within the department or who's going to be responsible. Because the worst thing is to have an emergency and to not have the drugs or equipment available that you need in order to, decrease mortality in the patients. So first of all, I would like to know, of all the participants today, how many actually have a difficult airway cart developed? You can just put it in the chat, please.
Okay, participants, welcome to share your experience. But do you have a difficult airway cart in your settings? You can write in the chat. So we will read from the chat. Also, meanwhile, we would like to welcome a question from the participants and announce some presence of a lot of participants from different places.
Dr. Mapa, I was going to say too, you could even try to ask some of the questions in Swahili as well.
Okay.
Yeah.
Yes.
Yep.
So also thank you, Dr. Faustina, for comment. She's saying that this is a very useful topic to our daily activities. I hope our students have know this in fingertips. Thank you so much. So thank you so much, Dr. Faustina, from Muhimbili National Hospital, anesthesiologist. And also we have Dr. Mulungu from Muhimbili National Hospital, and Susan. I hope, Dr. Gwen, you saw Susan here.
Yes, I saw Susan. Hi, Susan.
And
Okay,
Lukonge has Lukonge has their hand up. I'm not sure.
yes. So Lukonge, welcome. Anything to say?
Okay, thank you. For example, I'm working at the district hospitals. I meet with the difficulty intubation. For example, I meet with the difficulty intubation is airway does not visualize effectively, yani airway huwezi ukaiona kabisa. For example, huko wilayani na una hizo cricoid, hiyo cricocylotum, tasaidikaje hapo, afu tayari umeshampa suksa. Umeshaangalia airway, ukaangalia hii naweza kuingia, lakini ulipompa suksa, kumbe airway kuna shida, akacompress na hiyo cricoid nani pressure, lakini you cannot visualize the larynx. Na for example yuko peripheral kule, hivyo tunasaidikaje? Hili somo ni zuri.
Okay, so Lukonge, they are asking, you are in a remote area or peripheral area, and you anesthetize your patient. In emergency setting now, you use Suksa. But upon using Suksa, you find that you cannot have a good visualization of the vocal cords. I mean, you did the laryngoscope, you cannot visualize the vocal cords. So probably you are going to have troubles with intubation. So what will you do? And you are in a remote area. You don't have the QHSC. Na Lukonge hamna supraglottic airway devices, hamna LMA. Lukonge. Labda ungetuambia hamna LMA au airway. Because they say that they ask the question, what happens if you fail to intubate? So what they have is they fail to intubate. So that is the plan A. Now go to the plan B. Now we want to know if is LMA available, Lukonge, or you can write in the chat.
Lipo in the chat said most facilities in remote area, they don't have LMA.
LMA is basi kwa sababu tunatoa kulingana na body weight yake, unajikuta labda body weight ni kubwa ukilinganisha na hiyo LMA zinakuwa ni zipo ndogo. Kwa hiyo inakuwa ni issue sana unapoingiza kulingana na body weight yake. Kwa sababu zinaandikwa body weight 50 kg, sasa mgonjwa ana 60 kg huko. Mfano kama watu wazima waliopata accident. Ndio issue yangu kwamba labda sina option labda ya LMA ni ya 50 kg, lakini huyo mgonjwa ana 60 kg na sina hiyo ya 60 kg, nafanyaje? Na ninayo, ndio second option yangu.
Okay, now you okay. So they say that they don't have LMA, or they have LMA but a smaller size than the patient. So it could not be useful at that time. So Lukonge, labda mnanisikia hapo, you fail to intubate, that's plan A. You fail to utilize the or supraglottic airway device, that's plan B. Now we should go to plan C. We will do attempts of face mask ventilation. Now, are you able to ventilate that patient by face mask? I hope face masks are there. So are you able to ventilate that patient with face mask? That's now we are in the plan C.
Yeah, I'm able to ventilate face mask. In a remote area, I'm able to ventilate with the face mask until that muscle relaxant will be wear off. Then I can wake up the patient. Nitamventilate na face mask, but then nitamwamsha, atabi transfer kwa sehemu ambayo wanaweza kumsaidia.
Yes, so that's the plan. Now in plan C, we successfully ventilate the patient. Now we are sure that the patient will receive oxygen. So, yes. So that now is what we were saying. That's now you are in plan C, and you are now doing you have done it, face mask ventilation, and you successful. So the aim is to attain oxygenation. Now you will stop and think. Should I wake up the patient? Should I have waiting for a senior help, or should I refer this patient? But at that time, you are sure your patient has received oxygen and good ventilation. So the aim is to prevent aspiration and to prevent hypoxic injuries from lack of oxygen. So you, in any way, you already help the patient, and you decide what to do next regarding on the setting and what you wanted to do. Maybe it's emergency laparotomy, but you failed to intubate. Will you allow them to continue with the face mask, or you will wake up the patient and transfer to further facility? So that's the plan. So Dr. Wayne, I can read from the comments, LMA and IGL not available in remote areas, sometimes even in a big hospital like regional hospital. Maybe should specify so as to see what can be done.
Yeah, so what I want to find out is if these devices are not available, then these devices are really mandatory in order to save a patient's life. So my question is, where would they get those devices from? If they're not, you said they're not available, but what are the challenges for you to get those in your particular hospitals, especially in the rural settings when you don't really have all the backup that you have in the regional or bigger hospitals? So I guess the challenge is like, where would you get those things that you need?
Okay, we are also here along with Dr. Mulungu. Can you hear us, Dr. Mulungu? Yes, can you help us?
Yeah,
Yes?
I think the topic is very interesting, and the issue is most these remote areas, they have very big problem in having most of the best things in anesthesia. So the issue is to make assessment before doing any anesthesia to patient. We have to do to make sure what do you have around, and the anesthetist is the one to try to arrange those things, communicate with the management at least to have some of the things. But it's my experience in most of the health centers.
If we have this problem, if this problem exists, and we know that we have this problem, then what would be the next step in resolution? Where would individuals go? Who in the hospital could, fend for the rights of the patients and the rights of patients to live by getting the necessary equipment that they need, in the facilities, especially in the rural facilities? What would be the process to get an LMA in a rural facility? I guess that's my question.
Okay, maybe we should listen from different experience, because we have participants from regional hospitals, health centers. Maybe they should share with us that if you have a lack of something, do you go to the management here, or what did the management say about that? That I don't have LMA and I need to have LMA. What the management says, maybe they are available, but there are a lot of processing, a lot of logistics to get them, or they are not available at all. So we have different participants you can raise and say.
Maybe in addition on it, I'm Lukonge Masunga, in addition on it, if we wanted to get it RMA and the other equipment necessary, we do always consult pharmacist for the procure it to the MSD. That is, we get it from it. If there is no, if MSD does not it, they go to Mstiri for the procurement unit. We do that on our district. I can say that.
Okay, and when you do procurement or you order these things, you order in different sizes or different type. You have to check size that you order, or it's just you get what is available.
No, we cooperate with the pharmacist to share the necessary and the different size before place the order to the MSD.
Okay, and how long does this order take to arrive to your units? What is that process?
Almost 1 month.
1 month.
Almost 1 month.
1 month?
Yeah, 1 month. For example, you have maybe, for example, you have ETT almost 30 or 35. Maybe you learn for 1 month, you use almost 20 or 15 before many 15 is here. You request it to the pharmacist, then to order it, the different size, wherever the necessary, before 1 month is over. before local.
Okay. Okay.
Yes.
What about in the rural areas? You know, the more remote areas. What is the process there to get equipment that you need?
The process on the remote area, we have in our remote area, we have the therapeutic committee, we sit, then everyone share what they need, the necessary, the committees, then the pharmacist note them, then request it to the MSD, then whenever the equipment come back to our facilities, if it's ready, we counter check it. What are the necessary we have ordered? Is it correct? Then display it to the consumer.
Okay. Now, do you actually have difficult airway carts, or how are difficult airways managed in these different facilities?
We have a difficulty, but before difficulty, we make assessment, the airway assessment of the patient before anesthesia the patients. If this patient is difficult, we transfer the patient to the high facilities, from the remote to the high facilities, where there is a capable, the anesthesiologists are present. For example, the video laryngoscope are present, ENT surgeon are present. We do that before anesthesia the patient to clear it if this patient is fit or not fit. Then we clear it with the form. The surgery will be postponed, but transferred to the high facilities where there is a crucial, you suspect this is difficult. A crucial can be help this patient.
Okay. Okay.
Okay. Also, there's a question from the chat, Dr. Gwen. Petro is asking, he would like to know the capacity of one crash cart and number of patients. That if I have one crash cart, how many patients can it handle?
Oh, one crash cart? One crash cart should basically be stocked all the time, and it can handle as many patients as needed. Because if you have supplies, again, it goes back to your supply chain and having the sizes and equipment that you need for each patient. When I was there last time, we actually stocked a cart in one of the hospitals, and it was tough getting all of the equipment, trying to, organize and actually staying on top of everybody every single day. And so the question is, who is that person who's going to fight for the patients to the end? Because it's not easy. So, okay, it's coming. Okay, when is it coming? Is it coming tomorrow? Is it coming today? And just basically trying to, I guess, express the emergence of having this equipment necessary to sustain patients' lives should there be an emergency. And so it has to be like an aggressive a person who's going to take a very aggressive approach to making sure that the cart is there and the cart is stocked, and somebody has to be responsible for that. And so, again, it goes back to who is on the team and how is the team going to play this whole thing out. I can tell you, it was definitely difficult in trying to get the cart stocked, but once the cart was stocked, then it was a beautiful thing.
Okay.
So who's going to be responsible, and who's going to be that aggressive person to make sure that your hospital has what it needs? I was there for 2 weeks, and I can tell you the struggles and challenges that I had that time. But guess what? In 2 weeks' time, it was done. The cart was completely stocked. There was a person who was responsible, and so that's the way it has to be.
To piggyback off of Dr. Randall, like she said, if there's one designated person, so in the mornings, at least here, the charge nurse, there's a huge checklist and we check to make sure everything's in order. And then every time someone you need to use that crash cart, doesn't matter what time of the day, the charge nurse goes back and replenishes anything that was used. So like Dr. Randall said, it goes back to who handles the equipment and how fast you can get stock and supplies into the crash cart to keep it sustainable.
Right.
Okay, right after that, I would like to return to the host, maybe to conclude the meeting.
Okay, any other questions for Dr. Randall or Dr. Mappe?
I just want to add some. Hello?
Okay.
Yes,
Yes, we can hear you.
Yes, because the for the government now is always is now very enthusiastic in establishing the operating theaters everywhere, almost in every district, in every centers. I think the theater team is the one is supposed to be responsible in making sure they have this cut. If only they don't have the cut itself, as you said before, Dr. Green can have maybe a box with arranging all the necessary equipments. So if they can have the suture, they can have the gauze, if they can have everything for the operation to be done, they can also arrange themselves to have everything to provide safe anesthesia. So I think the team from the theater team themselves, from the management, if they can afford to start operation in that hospital, in that center, so they have the same to make sure those patients are safe at every angle. So I think
right.
when the time, if the government says now, maybe a certain health center have to start doing operation, that's the right time to start arranging everything at a go, because you cannot just so do so many operations. As my experience, these surgeries are being done, and if they allow the health centers or the district to you anesthetists, if I can start with, and the theater team themselves, if they can allow themselves to embark in doing any type of operation, they have to think about safety of the patient. So they have to be very much aggressive, starting from those people living, who are in the four walls of the operating room. They're the one to start it. You cannot start doing surgery because you don't have 1, 2, 3, 4. So together they can sit in the management. Okay, now we have to have safe surgery in our center, in our hospital. For us to have that, we have to start from what we need. We need 1, 2, 3, 4. So when they buy the theater gowns, if they buy the suture, they can also buy necessary things to make the anesthesia safe. So there's no other person from out of the operating rooms can arrange all those things. So it just starts within the operating room team so that they can manage those things. And I'm sure they can have most of the things. They can have the cut itself, but they can at least have some equipment and find some box somewhere to have those things. It's possible. So
right.
They don't have to think about who will be responsible. Those ones who are putting the patient to sleep, those ones who are cutting the patients, those are the ones to start with, because safety is not just from cutting and that, it starts from anesthesia itself. That's what I can think. Yeah.
Right.
Yeah.
Well, also in the ICUs, it's the same thing. Everybody, wherever a patient has the possibility of being anesthetized or intubated or an emergency room, ICU, the OR, all of those places should have adequate equipment to save a patient's life. And airway is number one. If the patient can't breathe, the patient can't live. And that's how you have to look at it. There are no options when it comes to that. So I'm putting a challenge out there for everyone who's on this web to go back to your facilities and make sure that if you don't have a plan, to implement a plan and to make sure that you follow through and make sure that you have everything that you need for your patients in the situation of a difficult airway, because there is no other way other than to have the equipment that you need for when you're faced with the difficult airway. So my challenge to you today, and report back to us on how you're making out with, following through and doing some of the things that you need to do. And I can actually put on the web just pictures of, a tackle box, like a fishing tackle box. It may have 3 tiers to it, and you just put equipment in there if you don't have a actual difficult airway cart. But there definitely needs to be a plan.
So if there's no further questions, I'm gonna give you guys back your Saturday. Thank you for everyone in Tanzania for joining us. I know you guys are starting your evening, and for us in the United States, we're starting our morning. So thank you, Dr. Randall and Dr. Mappe, for hosting the meeting. And don't forget to put your name, your email, and what hospital you work in the chat if you guys can before you leave.
Asante kwa toka mkutano.
Asante sana.
Asante.
Okay, guys.
Asante sana kwa mkutano. Thank you so much, Dr. So long we have not seen each other. I was not even around in some of the meetings, but I'm around now. So we keep in touch and see how things are going on.
Okay, bye, guys.
Bye.